Our second topic is PCI in low ejection fraction patients. So we'll start with a poll question. And this is just a personal question, which I'd love to hear. Actually, I was going to ask Dr. Croce that question. Can you go back to the poll, please? Sorry, somebody's, okay. So in the last 3 months, have you performed PCI for the sole indication of low ejection fraction? So we'll put you on the spot while the others are answering. Kevin, what would you say the answer to that is?
Yeah, it's a great question. And I'm usually the person in CTO forums that asks this, because you think about the benefit of complex PCI, but especially CTO PCIs for symptoms. But we often get asked by our heart failure colleagues to do a complex, difficult revasc in a low EF patient for the fact that they keep having heart failure. And, there's no data on that, but I do them in that particular example. Asymptomatic low EF multivessel disease. Recent data suggests that maybe we shouldn't be packing these as aggressive as we have, but I've done them recently to lessen heart failure admissions, not knowing if a lot of hard work and risk to the patient is really worth it. But, I think we don't have an answer to that currently. Okay,
awesome. So we're going to have some discussion around that. So 68% of us were honest and said yes, 32% said no. It may not have been in 3 months, it would have been.
Yeah, I'm in the yes as recently as last week, so.
So with that, I wanted to share some data. These are non-ACS patients where the listed indication actually is just for a low EF. And what I was surprised by was how low this number is, 5.68%. So perhaps a lot of the patients that we are doing who have a low EF also have another indication. They have acute coronary syndrome, they have angina, or what we think is an angina equivalent. And, it is really an honor and a privilege to welcome Dr. Slocum. We've known Dr. Slocum for over 15 years. He is an interventional cardiologist in Traverse City and does not only complex interventional coronaries, but also structural heart and congenital heart. And he's going to be talking to us about revived BCIS2 and the role of PCI in ischemic cardiomyopathy. Nick, would love to hear your thoughts.
Great, thank you. Do I have control here now, Pam? I do, beautiful. Well, thank you for that introduction. And I love the direction of these questions as well as the discussion about the honesty. I think some of what we're talking about here is a little bit possibly changing practice patterns. And so I think that's an important part of this. It was a real nice opportunity to review the REVIVE study here for everyone. No financial disclosures to discuss. So there's a lot of interesting things to talk about with regard to this study. And many would suggest this was one of the most important studies in clinical cardiology in 22. One thing I was struck with when this came out, talking to friends and colleagues, was their reactions. I think there's individuals who felt that the results were a surprise and that the results would lead to them changing their practices, while others argued that these results are not surprising. And based on the trajectory of recent studies, these results were actually expected. So we know that revascularization and medical therapy play an important role in the treatment of heart failure and coronary artery disease. What these investigators sought to evaluate was the hypothesis that in patients with systolic dysfunction and severe coronary disease, PCI, when added to optimal medical therapy, would improve outcomes. This was a United Kingdom study funded by the UK Department of Health. First patient was enrolled in 2013. This was a little bit on the background of the prior studies such as STITCH and that evaluation of medical therapy versus bypass surgery, which I think we'll talk about a little bit more here in a minute. What do our guidelines say currently? For patients with stable heart disease, multivessel CAD, who are appropriate for CABG with severe elevated systolic dysfunction, CABG is recommended really based on the STITCH trial with a level of evidence B. Our guidelines don't say a lot about PCI, except for this one statement that there may be an advantage in PCI in this patient population if they're at high risk for open heart surgery. This is that important background study from Stitch, which is actually the 10-year follow-up of the Stitch trial. As you can see on the top in orange, this is the medical therapy. In blue is the bypass group. This was a pitting medical therapy versus bypass, and early on we saw this statistically significant change where there was a mortality from bypass, from the complications of bypass and things like that, that went away at the 10-year mark, and bypass was actually statistically significantly favorable for patients. Revive itself is a randomized trial of 700 patients. They excluded patients who had had MIs within 4 weeks, and they also excluded patients with acutely decompensated heart failure. Their definition of acutely decompensated was pretty significant. This was patients who experienced need for mechanical support and inotropes. The inclusion criteria were patients with ejection fractions less than 35% and described as extensive coronary artery disease. To describe the extensive coronary artery disease, these investigators used the British Cardiovascular Interventional Society Jeopardy score, which honestly was not a score I knew a whole lot about. I had to do a little research, and this is somewhat like our syntax score. It's a numerical estimation of coronary artery disease extent, and it goes from 0 to 12, 12 being the worst you can get. Just to set the table, left main alone stenosis is an 8, proximal LAD stenosis alone is a 6. Unlike syntax, this does not include CTO, bifurcation, calcification, and tortuosity. To get into the Revive trial, patients had to have a score of over 6, and the average patient had a Jeopardy score of 10. So a median of 10 essentially means the average patient in this study had severe proximal 2-vessel CAD. In addition, they had to have a viability study and had to have at least 4 segments that were amenable to PCI revascularization. Patients were then randomized to medical therapy alone versus medical therapy plus PCI. The primary outcome was a composite measurement of death from all causes and heart failure hospitalizations. There was also a secondary endpoint of ejection fraction measurement at 6 months and 12 months, which was done by a blinded core lab. So what did these patients look like? The average age was 70 years old. There was essentially no diversity in this group. It was 87 to 88% men, over 90% Caucasian. Important for us, if you look down at the symptomatology, the symptoms of these patients were relatively mild. 77% or over 70% patients were NYH 1 or 2. Canadian class angina, 66% patients had no angina, and another 30% had class 1 or 2 angina. So almost everyone was class 2 or less angina. The ejection fractions were low, averaging 27%. As I said earlier, the majority of the patients, about 50%, had 2-vessel coronary disease. Interestingly, this study did include left main disease. A lot of patients with left main disease were left out of trials, and this investigator group did a good job of 14 and 13% of patients who did have left main disease. So what did the medical therapy look like? Medical therapy was managed by heart failure physicians at the recruiting centers. The authors do mention that the guidelines were periodically reviewed throughout the study to refine pharmacology and device therapy recommendations. As you can see, at randomization, 21% of patients had an ICD, and at the end of the study, up to 53% of patients had ICDs. The medical therapy was pretty contemporary. As you see, ACE inhibitors used about 60% of the time. Another group probably who did not have the ACE inhibitor, 20%, are on ARBs. You see beta blockers used well over 90%. You see Entresto starting to be used at 26 to 33%. The investigators do put down here oral hypoglycemic agents being used at 28 to 29%. Based on the timing, SGLT2 inhibitors were not being used at this point in Europe, and so they did not play a role in this study. What did the PCIs look like? Median number of vessels done were 2. Median number of lesions were 2. You can see essentially all drug-eluting stents, 97%. And I would argue they performed pretty safe PCIs. You can see the bleeding risk or rate of bleeding was 4%. Access site complications were 6%, and less than 1% of patients with contrast-induced nephropathy. So what was their main result? This is their composite endpoint. You can see in orange, the PCI line. You see in blue, the optimal medical therapy, and there's no separation of these event curves at 41 months. There was a statistically significant no difference between these two groups, with the primary endpoint happening in 37.2 versus 38% patients. Unplanned revascularization was seen in 3% of patients who underwent PCI and 10.5% of patients on the medical therapy arm. And the acute MI rate was exactly the same at just over 10%. Looking a little deeper into some of those outcomes that you and I might be interested in, if we look at the acute MIs that were seen in this study, there were a relatively small number, 14 out of 347 paraprocedural MIs. So again, I think these investigators were performing safe procedures. Spontaneous MIs occurred 18 of the PCI group and 33 in the optimal medical therapy. I was very interested in this unplanned revascularization. Medical therapy had 10%, just over 10% of their patients required unplanned revascularization, with 3/4 of those being PCI and 1/4 of them, 8 patients, requiring bypass surgery. Stratifying some subgroups that we would want to know about based on age, ejection fraction, presence or absence of diabetes, atrial fibrillation. As you can see, there are no significant features, with every sub-condition crossing the point of no effect here. Next, and to me, this is a disappointing part of the study as well. On the top, you see the ejection fraction. So in blue is medical therapy, in orange is PCI out to 1 year. At 1 year, there's statistically no difference between the two groups, but more importantly, there's no improvement. The average ejection fraction improved by only 1 to 2% in this study. And again, no difference between the PCI and the medical group. So the conclusions that the authors drew were that in those with severe LV systolic dysfunction receiving optimal medical therapy, revascularization through PCI did not lower the incidence of death from any cause, hospitalization from heart failure, or improve their patient's systolic function. I think there's some important interpretations and limitations to this study as well. Most importantly, I believe this study adds to the growing catalog of knowledge that revascularization should be a second step in chronic coronary disease, with optimal medical therapy playing the lead role. Another way to think of this concept, a little more cath lab focused, is that our indication to intervene has to be different in acute coronary disease versus chronic coronary disease. The guidance and dissemination of that concept, which again might be challenging to some established practice patterns, is really on us as leaders of our labs, our health systems, and our referring partners. This study absolutely cannot be extrapolated to patients with acute coronary syndromes or lifestyle limiting angina. Again, these were a relatively asymptomatic group of patients. I mentioned the lack of subject diversity. There is essentially no diversity, which does inhibit the generalizability of these results. Important also is the follow-up and the duration. The ejection fraction study only went out 1 year. The study itself went out just 3.5 years. So will longer follow-up lead to a change in these results? Recall that in STITCH, there was an early procedurally related mortality or complication with bypass. There was a signal of that. In this study, in REVIVED, there's really no signal like that because the PCI was very safe. Despite the PCI being very safe, there's no difference at 41 months. Because of that, I think it's pretty unlikely that PCI is going to surpass the medical group in this study, unless there is a huge significant increase in spontaneous MIs or revascularization episodes. Next, and this is probably the let me go back one for you. Sorry. This is probably the most controversial part of this. And I think it's hard to interrogate this data without bringing up the possibility that ischemia was not the cause of the systolic dysfunction in some of these patients. Recall that only 50 to 56% of these patients had a history of MI, and that 62% had either one or two vessel coronary artery disease, but an average ejection fraction of 27%. And I'm not suggesting the investigators were nefarious, but was there a percentage of subjects with incidental coronary artery disease where the low ejection fraction was truly out of proportion to coronary artery disease? If that's the case, revascularization in these asymptomatic patients may not make a difference. Thank you for your time, and I look forward to hearing discussions and questions because this was an exciting topic.
So thank you so much, Nick. Wonderful presentation. There's a question from Imran Qureshi. Was viability done before PCI?
Yes, the viability was done before PCI. So we know that to be enrolled, you had to have segments that were viable, at least 4 that could be treated by PCI. What we don't know yet about this study is if true ischemia was noted with stress test, FFR, things like that.
Your perspectives on how this study will change your practice. And I'm just going to call on some of our colleagues as I see them. Dr. Pilsticker, has this study change your practice, or especially of your referring doctors? Have you noticed a change?
Can you hear me?
Yes, we can.
I'm in the medical therapy group.
All right. But what about your referring docs? Have they still been asking you to cath and stent patients?
They have been sending patients to the cath lab to evaluate the anatomy, and it's, I'll tell you, there is a wide practice variation. Some will initiate medical therapy and then recheck ejection fraction, but I would say that most will send patients to the cath lab to look for multivessel disease.
So this is an interesting challenge, because if you think about this study, and if you believe that these results should change our practice, then perhaps we should not really be doing a diagnostic cath in patients with low EF. It might be best to do something like a CT angio, and if they don't have surgical disease, then one can just treat them medically. I'm curious how many people feel that's a potentially viable diagnostic therapeutic option.
Yeah, I agree with that. I've been doing more CTAs. This is Mike Tucciaroni, by the way. I mean, like, particularly this patient, he was 9 METs, so 9 minutes on a treadmill with no symptoms. I understand his EF status, but it's a little perplexing. I'm not sure I would directly go to cath in these patients anymore. A lot of them, if they're doing well, I'll watch them, or at least I'll do a CTA, which I feel is a little more middle of the road and not invasive to give me a better option up front.
I would definitely agree. And if I saw this patient in the clinic, that's what I would have done.
So Hitinder,
please go ahead.
Yeah, and there's Mansoor. So why, if the patient is doing 9 meds and is feeling it has no symptoms, why would you even do a CTA? And then we get stuck with the information and don't know what to do.
Right. So I think it was a low EF assessment. Whether, right. I think that's a fair point, right? Like whether, I think your point is valid. If you've done a stress test, I think the concern in this case was that he did not augment on a stress echo, and if I'm reading it correctly, and there was concern that he had multivessel disease. But then the cath showed single vessel disease, but the referring and the patient wanted it fixed, and he got a fix. But it just shows the reality of how practice is, and that's why we wanted to show this case.
Yeah. No, I agree. And because once you see the anatomy, that's when the patient, the referring physician, the families, then you have to face them. Because so far, I think in the community, it's still the oculostenotic feeling that, you have a blockage, it needs to be fixed. Otherwise, I'm going to have a heart attack. And then you have to kind of wrestle with that.
Yeah, I think
How many people would IFR that first? I'm just curious. I mean, technically, you had no ischemia. I mean, I understand you look at the ocular reflex of the lesion, but you didn't have any ischemia, you know, in the standpoint of symptoms. It's a single vessel. So how many people would IFR that before they fixed it, just to have clarity?
I think that was
Just to be comfortable with fixing it. I'm just curious.
Yeah, I think it's a great question. I would have. I mean, I think obviously visually it looks severe, but it's relatively focal.
But didn't you say that, Raj, this is Eddie Daher, didn't you say that there was lack of augmentation and
There's global lack of augmentation, not focal.
yeah, so I don't know whether this was non-ischemic or maybe partly, but I agree. I mean, I think if there's any doubt, I mean, physiology is the answer for sure. But just, I mean, can I just say a few comments on the study? I mean, based on what Dr. Cross and Slocum said, I think it was a great presentation, and it's long overdue that we get on top of invasive, I mean, physiologic imaging and IRIS and OCT. But I think with regard to this particular study, I think I have three main, you know, kind of observation on this. One is that it's interesting that the study is published, and maybe it's coming down the line, but I think it was alluded to that there's no correlation with the viability data. Yes, the viability was obtained before, but we don't know the correlation with whether those arteries that were fixed were the arteries that were subtended, you know, supposed to supply these viable myocardium. And I think there's viability, and there's viability like we all know. So it's curious. I think when you ask the question initially on the first case, you know, whether you would open up these arteries with PCI, and see Dr. Cross said the same thing. I mean, I think a lot of us, you know, if you don't have symptoms, but there's viability, it's usually an ascending of a CTO, you know, and I've seen, you know, anecdotally, I mean, like really like significant improvement in EF if you do the based on really viability with PET or MRI. But I think the other two things for this study, I feel like we always come back to this thing when we compare medical therapy with PCI or with CABG, is the complete revascularization. With the study, they looked at BCIS, you know, which is the syntax score equivalent, and it was 70%, around 70%, you know, complete revascularization. So I think we're still, I mean, it's good. I think we're doing a better job, but I think we can do a lot better job, and like the surgeon do 100% or close to 100% revascularization. And then last but not least, based on our talk, I mean, the talk with Dr. Crows, I think a lot of these studies probably, I mean, angioplasty were not done with guided imaging. So the number one, you know, increase in MACE event was revascularization. So I bet you, you know, a lot of these, you know, stents that were put in were probably either too short, malopose, you know, not appropriately sized, minimum lumen is not more than 5 millimeters square. So all of these things. And the bottom line is, if we don't do an excellent angioplasty, we're never going to be able to show improvement over medical therapy or close to bypass surgery. I think that's my opinion.
No, I think Eddie, great points. I see a note by Dr. Saltiel related to whether we've seen patients who've had significant improvement in LV function after revasc. And you know, all of us have, if you do this long enough, encountered patients who felt remarkably better, who said they had no symptoms, then you fix them and they say they feel remarkably better, whether that's a placebo effect of the procedure or they truly feel better because they're revascularized and they didn't realize how much they were limited. But I'm curious if anyone has any thoughts, and I'd love to hear Dr. Croce's perspective on that, on identifying which those patients might be, on how we can identify a patient who we think is asymptomatic and would benefit from revasc just for a low EF.
Yeah, I think, you know, Revive, it's a great question. Asymptomatic is tough now. You know, the thing I worry about every study like this is that they're going to start to apply it to people that have recurrent heart failure, class 3, class 4, which is the majority of cases we get asked to help with. You know, the improvement in EF, at least in the CTO literature, has only been alluded to sub-hoc, not primary endpoint for LEDs. Although we've all done patients where we've done, you know, a couple vessels and they've gone from 35 to near 50. And so trying to know which patients are going to be in that scenario is tough. It tends to be in patients for whom there's a lot of viability and a lot of ischemia. So we have a pretty vibrant PET and MRI programs. I know many of you do. And so the times I've been really happy is when, you know, it's 38% ischemic myocardium with complete viability, and it involves the LED. Those are almost certain to get, you know, substantially better. But, you know, the circ and right PCIs, I'm always a little bit underwhelmed with those, especially if they're mixed infarct and ischemia.
Thank you so much. And that was we also wanted to be provocative, and that's why we picked an RCA, an asymptomatic patient, for discussion. And we hope that's not a very common scenario.